Hello guys, welcome back. Thank you for watching my videos. I hope you'll keep watching, and if you haven't already subscribed, please subscribe. Okay, let's take a look at our sedatives and analgesics that we commonly used in the ICU. Here we have fentanyl, morphine, hydromorphone, what else? We also use remifentanil and meperidine or the Demerol and or Petidine. All of these are opioid analgesics that are commonly used in the intensive care unit. Do you have anything else in mind? What about non-opioid pain relievers? We have ketorolac, ibuprofen, and acetaminophen. And let's add ketamine, alright? How about the sedatives? We have our benzodiazepines, such as the midazolam, diazepam, and lorazepam. These are the most commonly used benzos in the ICU, okay? What other sedatives do we use? We have propofol, dexmedetomidine or deprecidex, haloperidol, and I would like to add also ketamine to this category. These are the sedatives and analgesics that most often than not we will encounter in the ICU. We will go over each one of these individually in my next videos. Alright? However, in this video, we're just going to talk about the general information that is important to know about our sedatives and analgesics we're commonly using in the ICU. Remember that opioids bind to opioid receptors in our body, targeting the spinal cord, specifically in the dorsal horn of the spinal cord, inhibits ascending pain pathways, thus altering response to pain. As a result, increases pain threshold and produces analgesia. Opioids are central nervous system depressant and can depress respiratory center in the brain stem, can suppress cough in the medulla, can decrease gastric motility, and a high dose can cause sedation and hypotension. It is also critical to emphasize that opioid dose requirements vary greatly between individuals, and that the effective dose of an opioid is determined by each patient's response, okay? It is determined by how patient responds to the dose that you're giving to them, not by the drug's recommended dose range. Alright, now let's talk about some of the adverse effects of opioids. When opioids are given in unusual dose, they can cause a centrally mediated dose-dependent decrease in respiratory rate and tidal volume. But respiratory depression and hypoxemia are uncommon. Opioid doses that suppress arousal also suppress ventilation, resulting in accumulation of carbon dioxide or what we call hypercapnia. It can also cause respiratory depression in patients with sleep apnea syndrome or chronic hypercapnia. Opioid analgesia is frequently accompanied by drops in blood pressure and heart rate, which are caused by decreased sympathetic activity and increased parasympathetic activity. These side effects are usually mild and tolerable, at least in the supine position. Blood pressure drops can be pronounced in patients with hypovolemia or heart failure, or when opioids are combined with benzodiazepines. But opioid-induced hypotension rarely endangers tissue perfusion, and blood pressure responds to IV fluids or small bolus doses of vasopressors. Okay? Opioids are well known for their ability to depress bowel motility via the activation of opioid receptor in the gastrointestinal tract. This is a source of troublesome constipation in cancer patients. In critically ill patients, impaired GI motility can promote reflux of enteral tube feedings into the oropharynx, creating a risk for aspiration pneumonia. Opioid can also promote vomiting via stimulation of the chemoreceptor trigger zone in the lower brainstem. All opioids are equivalent in their ability to promote vomiting. Replacing one opioid for another sometimes resolves the problem. Okay? Non-opioid analgesia used primarily for pain control in the early post-operative period. They can be used alone for mild pain, but are used in combination with an opioid analgesic for moderate to severe pain. The goal of combination analgesic therapy is to reduce the opioid dose or to have opioid sparing effects, and hence reduce the risk of an opioid-related adverse effects. Anxiety and related disorders are observed on the majority of patients in the ICU. Anxiety is characterized by exaggerated feelings of fear or apprehension that are sustained by internal mechanism more than external events. It can be observed in the form of agitation and delirium. Although delirium is often equated with agitation, there is a hypoactive form of delirium that is characterized by lethargy. But the common denominator in these disorders is the absence of a sense of well-being. So, sedation is the process of relieving anxiety and establishing a state of calm. This process includes general supportive measures like frequent communication with the patients and families, and of course, drug therapy. The drugs used most often for sedation in the ICU are the midazolam and propofol. So, benzodiazepines like midazolam are currently the most popular drugs for sedation in ICUs, but they are gradually losing ground to other sedatives like Precedex because of the problems with the drug accumulation and excessive sedation. Okay, it is not possible to completely eliminate stress experienced by an ICU patient because being critically ill is inherently stressful. However, some consideration may help to reduce the unpleasantness of the ICU experience, like critically ill patients experience pain in situations that are not normal, that are not normally painful. For example, being turned in bed is one of the most painful experiences reported by ICU patients, according to the study. And some of the patients even experience pain at rest without any noxious stimulus. This indicates that pain control is a full-time endeavor in the ICU patients. Unrelieved pain can be a source of agitation, so make sure that the pain is relieved before considering a sedative drug for agitation. Remember that. When a benzodiazepine is used for prolonged period, for example, over 48 hours of sedation using benzodiazepines, attention to preventing drug accumulation and prolonged sedation can result in a short time in the ICU. So the preventive measures include daily interruption of drug infusions or maintaining light sedation using reliable sedation scale to guide adjustment in the drug dose. So we have the RAS, right, the Richmond Agitation Sedation Scale as a tool. Then consider using Precedex or the dexmedetomidine for sedation because this drug allows the patient to be aroused while still sedated. So this may help nurses in repositioning or communicating with the patient or to let the patient speak with the family members. When arousal is no longer needed, the patient will resume the prior level of sedation. This is more like sleep than a drug-induced stopper. Okay? Finally, communicate with patients. Tell them what you are going to do before doing it and allow some downtime for patient to sleep. Alright? So that's it for this video. On my next video, we're going to talk about fentanyl, facts about fentanyl, the advantage of using fentanyl and some disadvantage. Also, we'll do some drug calculation. Alright? Okay, thank you.